Welcome, everyone, to our discussion about ground ambulances and the No Surprises Act. My name is Mark Morgenstein. I'm the Communications Director for PIRG. PIRG and the U.S. PIRG Education Fund, our research arm, have been leading consumer advocates for more than 50 years. And this is one of the issues that we are really focused on right now. High-value healthcare is very important to Americans of all political stripes, rural, urban, all races, religions. It really transcends politics. I'd like to introduce our moderator, Dr. Ritu Sana, and here he is.
Thanks, Mark. Good morning, everyone. For those of us on the West Coast and those of you on the East Coast, good afternoon. I'm Dr. Ritu Sani, and I am an EMS medical director outside of Portland, Oregon. Talk about that in a second. And I'm also a practicing emergency medicine physician in Portland, Oregon. We're going to talk about this issue today because EMS has had sort of a unique position in the No Surprises Act and balance billing issues that have been arising over many years. Obviously, many of you are fully aware of the No Surprises Act and the role it has played in trying to reduce balance billing in air ambulance or emergency department visits. But I think most people are surprised to learn that the No Surprises Act was actually silent on, or not silent, but did not include ground ambulance services. And at the time, ground ambulance services presented a sort of unique challenge, both in their structure as both partially public and private, as well as their funding mechanisms sort of being somewhat diverse. And as a result, the No Surprises Act then called for the creation of the Ground Ambulance Payment Benefit Advisory Committee, which one of our members of the panel today actually chaired and two of us served on. And so as a result, the issue of balance billing in ground ambulances is yet to be sort of determined. So what we'll do today is, again, I'll be your moderator. I'll give you a couple more pieces of background around EMS, and then we'll turn it over to our three experts for brief presentations. And then we will have some questions that I have prepared. And then we'll also have an open Q&A, which Mark will read off the questions. So if you have questions, please put them in the Q&A and we can get to them. All right. So Mark, it does look like we have the agenda on the screen. There we go. Now we're in presenter mode. Just a couple other pieces of information around the ambulance system and how ambulances work. I think most people don't really think about what is the system in place. They don't want to think about an ambulance. They don't want to think about EMS until they actually need it. And in a perfectly running system, that would be great. You wouldn't have to worry about it or think about it. But obviously, we have over 50 million EMS activations per year in this country, with over sort of 42 million completed missions. And in order to get that work done, there has to be obviously an infrastructure around the system. And financing of the system. And the issues around balance billing obviously have a great impact. I think what is also surprising to a lot of people is that they think of EMS or ambulance systems as an extension of their public safety net, which is a reasonable expectation. But nobody calls police and then gets a bill. Nobody calls their fire department. Well, most people don't call their fire department and get a bill. There are actually some areas that do bill. But in reality, most of EMS in this country is funded by billing insurance and patients after completion of a transport. So we know that about 55 to 60% of these calls end up in a non-transport, but it is surprising to many that particularly in Medicare, the benefit that pays for EMS is actually based on transport to an emergency department. and a hospital rather than transport anywhere else. And patients who are not transported are not necessarily paid for by their insurance carrier. So again, something that I think is unique and people don't quite understand. Also, I think one of the other pieces that we like to point out is that when you have an emergency, your healthcare starts the second that you pick up a phone and call 911. Our EMS dispatchers are trained in recognizing healthcare issues and health problems. They provide what are called pre-arrival instructions, which could be something very simpler, like lay down, or also something very complex, like start compressions or CPR on a patient who's had a cardiac arrest. Our ambulance providers are highly trained professionals, and our ambulances have very sophisticated equipment. And so we like to, again, say that your healthcare starts as soon as you dial the phone. Again, about a third of these interactions end up in non-transport. Some of them end up in your problem being managed by EMS and then being released. Other ones end up in patients refusing to go to the hospital, and about 58 or 60% end up in transport. So even though it's a public safety and a public good, it's not necessarily required in all states, although there are EMS systems in all states and territories. And again, it is primarily funded by insurance billing. So in that background, I think we can sort of jump into our conversation. We're going to go ahead and turn it over to Jane Beyer from the state of Washington, who is our state expert.
Thank you so much, Ritu, and thanks so much for the opportunity to participate in today's discussion. And so I've been asked to give you the perspective of a state who is one of about 16 states that have enacted their own state balance billing protections. So Mark, if we could go to the first slide. Washington State, just by way, that's slide number 3, if we could go back to slide number 1. Just by way of introduction, Washington State was actually one of the states that enacted our own balance billing law in 2019 prior to passage of the No Surprises Act. And then in 2022, we passed another law aligning our state balance billing protection act with the No Surprises Act. And both times, as the legislature was considering those new laws, we had requests from consumers and insurers to include ground ambulance balance billing in balance billing protections. But because of some of the complexity that Ritu referenced, the legislature said, okay, let's wait on this, let's study it, let's have a report back to the legislature. We established an advisory group with public and private ambulance providers, consumers, health insurers, and our partner state agencies, including our State Department of Health that licenses EMS systems. We held 6 meetings between January and August of 2023. We learned an immense amount. And we had people who stuck with us through every meeting and every discussion, and it was incredibly productive. Next slide, please. And in addition to having those perspectives sitting around the table, we also said, you know what, we need to have this be sort of a more data-informed process. So we reviewed EMS licensing applications. Washington State is fortunately one of the states that has an all-payer claims database. So we did an extensive analysis of ground ambulance claims in the commercial market. We surveyed health insurers, and we also surveyed ground ambulance providers and submitted a report to the legislature in October of 2023. Next slide. And this is always my favorite slide to show people. Washington State has 39 counties and 400 licensed EMS systems. 299 of those systems provide ground transport. And what we learned more than anything else was how varied the EMS systems were in terms of number of staff, in terms of their geographic region, in terms of their structure. Were they private? We only have about 7 private licensed EMS providers. The rest are public. It could be a hospital owned, it could be a fire district, and it could be a local volunteer fire department that's providing EMS services. And the other major thing that we learned is the public and private ambulance systems work together very, very much. Public ground ambulance, public EMS systems have a limited number of rigs. So if they respond to a 911 dispatch and they're out in a rural community with a massive geographic region that they're serving, they have to be very careful about whether they commit a rig to transport somebody 3 hours to the hospital. And so there's a partnership between public and private ground ambulance providers that's really important. Last slide, please. So here's where we ended up. The legislature did pass a bill virtually unanimously during our 2024 session. It prohibits balance billing of consumers for covered emergency and non-emergency transports. Although we learned, I think, as we know in a fair number of states, while emergency ground ambulance transports are covered and required to be covered in our essential health benefits benchmark plan, we don't require coverage of non-emergency transports. So there's some variability. And we applied our law to both public and private ground ambulance providers. And again, because of that massive variability in the size and structure of EMS systems, we did not think it was appropriate to expect that, number one, each of those systems was going to contract with 15 health insurers, nor did we think it was realistic to ask them to go through formal arbitration processes or even the No Surprises Act IDR process. So the legislature set a rate in statute, and essentially it says that the out-of-network ground ambulance provider will be reimbursed at the locally set rate, or if no local rate exists, at the lesser of 325% of Medicare or the EMS systems billed charges. And note that locally set rate could be two things. It could be, I'm a public system, this is the rate I charge when my rig takes you to the hospital, or it could be, this is the rate that I've contracted with a private provider, and they're capped at that rate. But because of all the questions around, is this the right formula? What impact is this going to have on consumers? What impact is it going to have on premiums generally and the viability of EMS systems? The legislature wisely expired the formula as of December 31, 2027, with OIC doing an extensive review of Medicare rates, locally set rates, what we see in claims data, and reporting back to the legislature in October of 2026. So that's how we approached it in Washington.
Thanks so much, Jane. We have a saying in EMS, if you've seen one EMS system, you've seen one EMS system. And there are a lot of professions, I think, that carry that saying, but I think you hit on a couple of the topics. In my two counties that I'm the medical director for, we have public ambulance, we have private ambulance, we have private for-profit ambulance. There are private nonprofit, hospital-owned. In my state, we have districts, so you can have an EMS district, just like a fire district. Some of which have state subsidy, some which don't, are tax subsidy, and some which don't. So again, the funding of the system is not uniform, which creates a big challenge, I think, when you try to build a finance structure which protects patients. It's also interesting to me to hear that your discussions, and I'm sure Asbel will comment on this, mirrored a lot of the discussions that we had at the ground and on the national side on the Ground Ambulance Payment Benefit Advisory Committee. So with that, we're going to turn it over to our next panelist, Patricia Kelmar. Welcome.
Thank you. Thank you. And thanks to everybody for being here. It's a really important topic. I'm Patricia Kelmar. I'm the Senior Director of Healthcare Campaigns for PIRG. And we work to bring down unjustified high prices in healthcare, which simply add to the expense for families, employers, providing insurance, and our federally funded health programs. We've been active in states and federally to end the practice of surprise billing by out-of-network providers. So it's really critical to solve ambulance surprise billing because so many insured patients are at risk of receiving these very expensive bills. Mark, if you can pull up my slides, that'd be great. First slide here is really just to show you kind of the prevalence of surprise billing for the insured population in the US. And I'll bring it down to a more personal story. On the next slide, I'll tell you the story about what happened to Dave and Christy. So Theo, baby Theo here, was born a little early, and when he developed breathing problems, the doctors told his parents that he needed to go to the nearest children's hospital right away. After the 16-mile ambulance ride, Theo was swiftly diagnosed and successfully treated, and the good news is that Theo is doing really well today. The bad news is that Dave and Christy received a surprise out-of-network balance bill from the ambulance company for $7,000. Their insurance paid $1,000 of the billed charge, but because the ambulance ordered by the hospital was out of network, Theo's parents owed the remaining $6,000. Christy and Dave appealed the claim with their insurer. They tried negotiating with the ambulance company to lower their amount due, but nothing worked. So they set up a 30-month payment plan. That means Theo will be almost 3 by the time the bill would be paid off. And this is just one story of many and why we really need solutions to this issue. So states have been leading the way. If you show the next slide, Mark, there are 18 states, actually, Jane, a couple of them just came online. We have surprise billing protections at the state level, and PIRG has been involved in supporting many of these campaigns. Yet even in those states, we need a federal solution, and that's because state protections don't apply to those with employer-sponsored coverage. And in most states, this is a type of insurance that most working people have. A federal ground ambulance and patient billing advisory committee was established, as we mentioned, under the No Surprises Act to make recommendations to Congress on how to solve ambulance surprise bills nationally. We jumped at the chance to serve as the sole consumer representative on the committee. So as a committee, we spent 6 months looking at data, hearing from experts, hammering out recommendations. The result of that work is a set of recommendations and definitions to go with those recommendations that will be couched in a comprehensive report explaining how we came to those decisions. And that report is expected to be sent to congressional leaders in the next couple of weeks. So let me take you through the policy solutions that the committee voted on at the end of last year. So the recommendations filled 2 goals. Mark, if you could just go to the next slide. So consumer protections was one set of recommendations, and then creating the payment process for ambulances that don't have a negotiated in-network rate with the patient's insurance. On this slide is the summary of the consumer protection recommendations. First, banning surprise billing from out-of-network ambulances in 2 situations, for 911 calls, but also for the emergency transportation from one hospital to another. These are called interfacility fees, interfacility emergency transfers, and they are becoming more common as all of the hospital consolidation has resulted in many closures of specialty units. That means patients might find themselves in the closest emergency room, but it doesn't have a cardiac care specialist or the equipment that they need. And so hospitals will have to order ambulances to move the patient to the hospital that does have that specialty care. Second, making ambulance billing much more clear. To avoid confusion for patients, we recommend that patients are not sent a bill until after it has been run through insurance. Bills should also include information about surprise billing protections and who to call if there are problems. Third, because many patients have had an experience with a high ambulance bill or know someone who has, we know that some are now afraid to call 911 because of the expense. To help patients make a decision to call for an ambulance based on medical needs rather than a looming large bill, we recommend that Congress establish a cap on how much patients pay out of pocket for emergency transportation. A cap would also protect patients from any potential cost shifting that we might see by insurance companies. Just like we have zero cost sharing for certain preventive services because we know that people will avoid care when they have to pay, we should be sensitive to the public health reasons for low or no cost sharing requirements for emergency transportation and services as well. We don't want people making unwise medical decisions because of fear of a high ambulance bill. So now we'll get to the second set of recommendations. How much should insurers pay out-of-network ambulances? We considered how different states address this question. Some states set an out-of-network payment rate tied to a percentage of Medicare rates. Some use what's known as the median in-network rate for that region for ambulance payments. And other states use the local contracted rate set by a county or municipal government, as Jane had just explained. This was probably the most contentious part of the work of our advisory committee, and some of the votes were very close. This slide reflects the payment structure that received the most votes and ends up as the recommendation from the committee. So the payment is based on a tiered system. This is how the recommendation goes. If there's a state law or an all-payer model in place, that payment rate is the amount that the insurer must pay the ambulance provider. If the state doesn't have a law, then the rate set by the local government rate is the required payment for the insurance company to pay the provider. And if neither exists, then the default would be a percent of Medicare rates. The committee did not make a specific recommendation of what that percentage amount would be, leaving that to Congress to set. Recommendations in this bucket also address some of the business aspects of ambulance billing, such as prompt payment. We also recommend that insurers pay ambulance companies directly rather than sending a check to the patients for them to send the payment along to the ambulance company. I will note that the committee did consider and vote on whether arbitration, as used in the No Surprises Act, should apply to ambulance surprise bills. And the recommendation did not win the majority support. So we can get into more details during the discussion, but for now, I'll pass it off to Asbel, who was our chair of our committee and worked us very hard. Off to you.
Thank you very, very much for that, Patricia. And first of all, I just want to say thank you for putting this together and inviting such an illustrious panel to kind of talk through some of these issues. The one thing that we kind of talked through, and I'm not going to belabor the point because Dr. Sani actually did a very good job of showing about the complexities. This is the whole reason why the No Surprises Act, why we were carved kind of out of the No Surprises Act and remanded to this advisory committee to kind of come up with a solution to Congress. And so we know that report's going to be coming out in the next few weeks. And so kind of aligning through what you heard in November, we'll kind of walk through it. And one thing that centered around it was the locally regulated rates, or the local jurisdictions that meet operational. A little background on me so you understand the lens that I'm going to be viewing this through is I've been in the ambulance industry since 1998, but very specifically in the financial side of the organization. So think reimbursement, understanding the reimbursement side, as well as understanding how policy interacts with the reimbursement in the EMS system, because the majority of what EMS does, as Dr. Ritu so aptly pointed out, is EMS is typically funded a lot by either state-funded dollars or locally tax-regulated dollars, but a large portion is going to be comprised of revenues that you receive from either Medicare, Medicaid, or commercial plans, hence the reason why we're having this discussion. And so when you look at it through those lenses, then you begin to understand, okay, the complexities of how each of the operational or organizational types of the EMS industry is going to be very important. So really understanding, and the committee had to understand, so explain to us exactly how operationally this works when you set a local rate, whether it is at a very local jurisdiction, or maybe it's the state that is setting the local rate. So we heard from a lot of individuals around that. That would say in different states, in different localities. We heard from EMS systems that were governmental based. We heard systems that were privates or hospitals. Kind of understand how those rates are set. And so that's why you see some of the stuff that Patricia just opined on related to the recommendation around if there was an all payers model, we would look at that because there are some states that have that. And then if not, it was going to go look and see exactly what the actual entity or the locality that was delivering the service to the patient. So there was a lot of discussion and debate. Is it really out of network for an emergency services? I'm not going to opine on that. I'm sure that'll come up in a question or a Q&A related to if really is emergency services out of network, but there was a lot of discussion around that. And then there was a lot of discussion around what the rate would be. And many settled on that it should be the state. And as you heard from Jane earlier, the state of Washington actually took up that idea, as well as 18 other states have kind of taken up that issue on how that relates to a local rate and how it is set. So it works different ways in different jurisdictions. In some jurisdiction, there's a lot of involvement. There's a lot of readings at the local, there's a lot of transparency. And in other jurisdictions, there may not be quite the same type of transparency. So understanding those nuances, it's relative when you're putting together a state type balanced billing provision. But what about the patient? And that is kind of what our organization, and where I'm a founder managing partner with my business partner on a healthcare technology service that we do at Solutions Group. And we do a lot of consulting services around this. So what does that look like through the eyes of the patient? That's our motto. And that's kind of our mantra, is how does the patient view this? And what is their impact? And Patricia gave a great story that happened in the state of Washington relative to somebody that experienced that. And so how do we deal with that? How do we grapple with the areas and the rural areas where we're starting to see a lot of operational challenges happening around 911 or these longer distance transports? And so this is what the Gap Back Committee and some of those challenges that you'll begin to see. The one thing that I thought was very notable that had 100% consensus of all of our stakeholders, whether you were within the EMS factor of the industry or you were on the patient advocate side, as Patricia was. We had individuals there from the different branches of government that had purview over this, as well as academia. The health plans were actively represented, but we had a 100% agreement on some definitions. We kind of looked at the core definitions, and one that was really relevant that actually Patricia brought through to the committee was when the patient arrives at the hospital via 911, and maybe they're in a rural area that doesn't have the services and they needed to be transferred for continuance of care. It got a little, there was a lot of misunderstanding in the industry and others of why sometimes that's considered a non-emergent type of transfer, and sometimes that's why it's an emergency transfer. And so the actual committee coalesced around a definition around an emergency interfacility transfer that was really trying to get at what is that and make an adoption of that. Because as you know, this only applies to what we're talking about on the commercial side, but a lot of practices might be looking at definitions that are maybe developed by a state Medicaid agency or or Medicare or in a Medicare Advantage program. And so continuity of the definition kind of takes the patient out of the middle to really understand from their perspective, if they don't get this type of treatment, then something adverse could happen, which is the continuation of that emergency. So there are some things and challenges and discussions that were had. We looked at a lot of data. Data was key. And unfortunately, when you look at all claims payer data, most of the industry, and there were some aha moments, that the ambulance industry typically only gets reimbursed very specifically in Medicare programs and a lot of your Medicaid programs if the patient's actually transported. But what we learned through data was that there was 30 to 50% of some calls and responses, depending upon where you're at in the region, where it may have just been an ambulance call and an ambulance responded. They may have treated the patient and the patient refused. There was a lot of things that happened around that, a lot that happened in the behavioral health space. I think that was important to note that in the Washington recommendation, they talk about some behavioral health side of things and to make sure that there were coverage issues. So you see that as well in some of those recommendations and grappling and understanding. So in one of the recommendations, as Patricia kind of alluded to the fact that there was some mandatory coverage type recommendations, and one was related around that it should be a mandatory coverage for an ambulance response, but no transport. There were other things that you will see too, because there was a lot of findings, of course, and we had a very specific charge within the No Surprises Act that looked at a certain provision, and there's a lot of other factors that should have been considered. So you'll see a findings section. And we alluded to this in the last public meeting around findings around mobile integrated healthcare. There's a lot of EMS out there doing things in the community that might be outside of a 911 response that keep patients out of the 911 system, keeps them from making sure they don't have specific out of pockets that they may not have normally experienced because EMS can't bill for those type of things. So really hearing there's a lot of innovation happening within the insurance industry side of things. So we heard from some carriers as well that we're actually starting to dabble in this, look at this. There was a demonstration program that was done by the Centers for Medicare and Medicaid Innovation around some of these concepts as well. So you'll see some findings, but we, of course, as a committee could not get down and explore to make recommendations. So there's a whole finding section that's really relevant to how charge masters are developed, specifically because there's a lot of responses and care that is given in the EMS system that most in the healthcare industry would call that as unreimbursable or uncompensated. Unfortunately, in many areas, the patient then becomes responsible for that type of care as well. And so that was a little bit about that. And I'll kind of send this back over to Dr. Sani because I know there's a lot of questions. We want to get to your questions, but thank you so much again, Patricia, for inviting.
Great. Thanks, Asbel. Yeah, so this is a panel discussion and we're here for your questions. So I saw one question so far, a couple of comments. So please go ahead and start putting your questions in the in the Q&A portion, and we want to try to get to those as soon as we can. I do have some kind of panel discussion type questions for you all that we're going to kind of hit on. I'm going to first look at Patricia and Jane as the non-EMS people that are on the panel. You know, you both got pretty involved. Again, Jane, your process sounds eerily similar to the process that we did in the Ground Ambulance Patient Billing and Advisory Committee. So what was the most surprising to you about EMS and ambulance and this whole kind of, I hesitate to call it an industry. Of course, it's an industry, but service that is provided to our public. And I'll start with, well, Jane, you're unmuted, so you can go first.
Okay. So very definitely the most surprising thing was the comment that I made in my presentation, 39 counties, 400 EMS systems, acknowledging that communities are interested in having a service in their community. And that could mean a relatively small community that's working alongside a fire district or a fire department, or even independent of that. And I think the other surprise and the variability of those systems. And then I think the other surprise was really gaining an understanding of how one call to 911 can involve two providers. Public provider responds to the dispatch, private provider does the transport. And we also had a lot of discussions about treat but no transport. We actually, our legislature and the legislation also directed us to do an actuarial analysis, which we're beginning now, around what it would cost and what impact it would have on premium to cover those treat but no, those 30% of dispatches that don't result in a transport. So we're getting ready to start that work now.
Patricia.
Yeah, I think that, you know, this concept treat but no transport it was one that I hadn't really thought about before. So obviously emergency services have advanced, and we know that we can do more treatment in the field. And to understand that some of the, well, in many payers will not pay for any kind of ambulance response that doesn't actually result in transportation to the hospital. And when you think about trying, as I do, trying to always minimize exposure to costs and raising up prices, why would we want to expose a patient who doesn't actually have to go to the hospital, expose them to the incentive that an ambulance provider might have to bring them to the hospital so they get paid for that service that day? So if we can treat people in the field and give them the care that they need, and then just encourage them to check in with their doctor next week, we should be doing that, and we should acknowledge, there should be an acknowledgement in the payment system that that is saving both the patient and the insurer extra costs in emergency care, in emergency rooms, possibly, you know, a whole gamut of tests that have already been done by the regular doctor or will be done the next week in a less costly setting. So I think that that was really a shocker to me. The other thing that I would mention is there is kind of this myth out there that people just randomly are calling the ambulance all the time, and that there's a bunch of people who just like ambulances coming to pick them up. And we did look at the data. And yes, there are some people who will call and actually don't need ambulance care, but not enough that we need to make a policy that addresses those, you know, poor actors, poor decision makers. So I think there should be some acknowledgement of that, but also let's look at the data and let's really address the problems that we are seeing in the data.
Yeah, great. Yeah, it was. Oh, go ahead, Asbel.
Go, Dr. Soni. I think the aha moment as well for not just what Patricia's saying and Jane's saying, what they did at the state of Washington around this, was also when we begin to review the data. So we were looking at data from Fair Health that brought some information around and let us kind of see what was the actual claims data around an ambulance response no transport, and how did that marry to the data that came from the Office of EMS through the National Highway Transportation Safety Administration. And so, of course, data is data. It always has to be cleaned. We know that. You can paint a picture on anything data related, but it goes to the point that Patricia was making. There is not as many bad actors, or what we in the industry call frequent flyers, that are calling the 911 system inappropriately, where you would have to address it from an exception standpoint. So that's kind of the data repositories that we're looking at. There's a lot of other anecdotal data out there, but I think it was an aha moment, even for individuals that were in the ambulance industry as stakeholders as well, and not just from the health plans, academia, and Patricia from the patient's aspect.
Yeah, as an EMS medical director, you know, I'm responsible for the healthcare that my systems provide. And for me, it was interesting to see the non-medical folks, Patricia, some of our other, kind of like go on about like, this is a really intensive healthcare industry also. You know, I think there is a lot of perception that we're just going to come and put you on a stretcher and take you off to where the doctors, you know, heal you. And as an emergency doctor, I'm one of those doctors. But, you know, we really know that our care in the emergency, in the ambulance, in the pre-hospital system, in the patient's home, actually ultimately impacts the patient outcome. Our care on cardiac arrest obviously plays a huge role on whether people survive, but also things like severe respiratory distress, heart attack, stroke. We play a huge role in reducing patient morbidity and mortality. And so it's really important that this is not only looked at as a transportation benefit, but as a healthcare enterprise that we are. So we have a couple more pre-made questions, but we really want to get to yours. So I've got, we're going to try and do this quickly. One other question I had for you, Asbel, you talked a lot about what we kind of consensused upon. There was a couple of things where we couldn't reach consensus on. What were some of those? There's a couple. There's one big one, but you know, where did we have a hard time coming up on a consensus in the process?
I'll know, generally speaking, and I believe this was addressed in the state of Washington, was around non-emergent transport, and we kind of ran out of time. Yep. What we addressed anecdotally through some definitions on these interfacility, and Patricia brought a lot of examples that happened where patients were going for higher level of care. where they may have been going from one hospital to another. I think, Ritu, you brought this up as well as another rural hospital, that sometimes a patient could be sitting in a small rural hospital or a small level 3 or a level 3 hospital needing, but there's not a bed available for them for 6 to 8 hours. And so oftentimes they might be billing that as a non-emergency that's interpreted as being out of network. And so should there be something around that? So generally, we did not make a recommendation on that. That did not go forward because there was not enough dialogue and data that we were concerned about the infrastructure. And generally speaking, a lot of individuals in the industry as well as academia thought that the markets should really prevail in that area, but there are some areas. So that was a lot of dialogue around that. You'll see some things around the findings of that. Hence the reason why we had a definition that would try to encapsulate some of that as well. The other piece that we couldn't get to on was, Patricia referenced that, was around, should there be an arbitration process very similar to the independent dispute resolution process? I think generally your sentiment would depend upon where you are, especially if you're in rural areas. Do they have where you have small patient census? Do they even have the infrastructure in place for that? Hence the reason why we looked at locally rates, came up with a percentage, which is why you don't see a number in there. There, generally speaking, there was not going to be unification on that, and that really should be something that states look at, and that was left to Congress. So it's interesting to see now that we've got 18 states, and you can probably track that back 3 or 4 years. Look at that. You're starting to see more around that because really the states know healthcare is local. The states know that more than even the federal side of it we'll look at. But for states that don't address it, Congress is going to have to address something around that piece of it.
Thanks. And that comment, healthcare is local, actually is a nice segue into the other question that I had. And then we can again turn it over to the questions from the audience. But I guess healthcare is local, but we're talking about a federal solution. So I'll start with Patricia. What should Congress and the states do now?
Well, we need the federal solution if we are going to ban surprise bills, because states can do everything they want, but if you're on an employer-sponsored coverage, that's considered an ERISA plan, and those state laws just won't touch them. So as we saw in the No Surprises Act, there was deference to states that had jumped on, and solved this problem initially. So we could be seeing that same kind of thing from Congress, letting the states continue to do the work that they've figured out is best for them and give deference to the states, but have that apply to the employer-sponsored plans as well. So that's why we still need a federal solution, but I'm just delighted to see that the states are not waiting and they're protecting the people that they can.
Okay.
And Ritu, if I can jump in on that, we absolutely agree that there's a federal solution that's needed. In Washington state, because we passed our underlying balance billing law before Congress had acted, we put a provision into our law that allowed self-funded group health plans to opt in to our program so that they could provide those protections to their employees. And lo and behold, 450 self-funded group health plans representing about 500,000 covered lives have opted in.
Wow.
And when the No Surprises Act passed, we thought, oh, all of those employers are just going to go with the No Surprises Act. Well, that has not been the case. And we think that's not been the case for 2 reasons. And now there's actually more reason to opt in because of ground ambulance protections. Number one, in Washington state, we do not allow providers to ask individuals to waive their balance billing protections under any circumstance. And number 2, in Washington state, and we totally appreciate the partnership with the federal government on this, we expanded the definition of emergency medical services to clearly include behavioral health crisis services. And along with that, in the bill that we just passed, we are requiring coverage of transports not only to hospitals, but also to behavioral health crisis facilities, like crisis stabilization facilities. And we did that through some creative interpretation of the No Surprises Act that the tri-agencies, the HHS, DOL, Treasury were partnering with us on and very supportive of. And so we really like the idea of Congress deferring to states that have taken
Right.
this on, especially where we've offered greater protections to consumers.
Asbel, from the industry perspective, your thoughts?
I think Jane summed that the intent has always been, because healthcare is local and what they need in Washington might be a little different than the state I live in, which is I live in Austin, Texas. It's going to be a little different. It's going to be a little different in Florida. And so really, however, because of ERISA, there is going to have to be these options, such as Jane mentioned. They can opt in right now, even without a federal solution. But for those states that haven't addressed it, like the state of Washington has, the feds are going to have to do something around that. And they're going to have to address it if we're going to balance bill, which generally there was unanimous consent. That was the first recommendation, was that we need to ban the ability of patients being billed for something outside of their co-payments, co-pays, and deductibles. And then we also talked a lot around mandatory coverages. There is certain things that maybe states have addressed in the essential health benefit, but what we did find out by talking to a lot is that it's not clear enough. So we had to be very defined in some of the way the essential health benefit is, that it does include ambulance. There was some of that stuff that we had to talk through. And there was another thing that I believe, I can't remember who did that. It's probably in the report, but this was around maybe a maximum copayment, because what happens is, if we can balance bill, there was a concern that there might be some coverage issues. And I even see that the state of Washington and other states have aligned to that of providing reports. Do we see something relative to coverages? The current No Surprises Act requires that from the GAO and others, kind of look and see, are we seeing some things with coverages that could cause a problem and ultimately impact the consumer?
Yeah, exactly. As the EMS medical director and as the doctor, I mean, I have just two other thoughts on this, and then we'll turn over to Mark for the questions. One, there was no discussion about whether or not we were going to ban balance billing. Everybody, top to bottom, healthcare provider, ambulance provider, obviously Patricia, insurer, felt that balance billing created a barrier to a good healthcare, and everybody wanted to fix it. But it was the yes and component. It was, how do we ensure the survival and safety of our community by making sure that the EMS system is still secure? And I think that was a lot of the definition, a lot of the discussion. The other thing too is, just to sort of point out that, a lot of this discussion was around treat in place. And as the doctor, I get to point out that it's my job to make sure that that's safe and that patients who are not transported to the emergency department are managed safely, securely, who are do not end up with increased mortality because they don't go. I am going to turn it over now to Mark. I know we have some questions in the Q&A, and hopefully we can take a look at those.
Yeah, I'm going to try and keep the discussion flowing from where it was, rather than just going in the order that the questions came in. One of the questions is, what jurisdiction or country is the best ambulance billing system today? Can we model that even if we don't have a national healthcare system, or is it just that the USA is an outlier in healthcare?
Asbel.
I that is such a subjective question. The moment you start naming one system over the other, there are some that are out there that indicate from a modeling perspective, you can look at it from a cost perspective, they're pretty transparent through that piece of it. But the moment you start naming it, and I hate to say that is such the political response, is there the one system over there? Because you might have somebody, I might say, for instance, the Austin Travis County system of the city that I live in is a high priority system. They are, in my opinion, but I could have somebody that lives in the state of New York that thinks FIDNY is the system as well. So is there some out there that have certification levels that you look at for whether a governmental system, fire departments, there are some like that? Ritu, I think this is probably more appropriate coming from the emergency physician's perspective that really works with EMS. Is there a system, or is this more local to the communities if they have certain parameters and benchmarks. I think it really gets down to the data and the qualitative outcomes.
Yeah, I think that the reality, I mean, again, you've seen one EMS system, all healthcare is local, blah, let's repeat these platitudes. But the reality is, I think the best way to approach this is to, instead of being kind of like system driven, this is the best system, is to be outcome driven, because local resources are going to drive what resources you have. And so instead of saying we need to do this exactly like they do in Austin, Texas, where they have a really great system built by my friend Ed Rocht and Mark Escott, who runs it now, but they have a different resource set that I have in Portland, Oregon. But what I can do is measure my outcomes. I can tell you that in my system, anybody with a heart attack ends up at a hospital that can take care of them right away. And we should be reporting that to our communities. And so being outcome driven is a key component of how you should measure your system. And the difficulty is, how do you then build a funding structure that drives you to be more outcome driven rather than system design driven?
Okay, we have a journalist who says, I think a lot of people in the public will read my articles and all the technical payment pieces therein and wonder why the government does not provide this as a community service. Did the committee consider whether this should be a government service, full stop?
So we didn't. We didn't, but people should know, I mean, emergency services were set up as a public service when we first started the emergency services system in the United States. There was a report that said, we could save lives if we got people to hospitals quicker. And there was federal money that was given out to all the states to set up these regional emergency transport systems. And then we moved to block grants for states with their health spending. And some states kept money in the emergency transportation system, and other states put it to other uses. And that's how we've ended up with this really diverse set of ambulance systems, with publicly owned and the fire department playing a role. And so we used to have that. It is a really important public policy question, whether we should be moving back to that.
Right. And I would add that question came up during the legislature's deliberations in Washington State. And there is direction in the bill that the legislature passed to an entity in Washington State called the Washington State Institute for Public Policy to put together a study and report to the legislature as to whether we should have what is essentially a firehouse model to fund EMS services as well. So we'll be submitting that within a couple of years. I think it's a long wait, but thoughtful work.
What is really interesting is that in the majority of states in this country, EMS is not even a locally mandated service. In every state, police and fire are, but ambulance and EMS is not. That in particular, in my state, a home state now of Oregon, it is. Every county is legally responsible providing ambulance service to every one of its citizens, but that's actually the rarity. So that's also one place to look at legislatively, is to make sure that everybody has access to the service.
And that leads perfectly to this comment/question. Almost all EMS agencies are out of network. Medicare doesn't even pay close to the cost. There's a revenue problem, capital equipment, medication, costs outside EMS control. If Medicare, private insurance, and the patient aren't paying, how will EMS survive?
So that's a very good question. And that was heavily deliberated in the committee. And you will see that extensively through why they came up and why we came up with some of the recommendations that we came up with. You'll also see a finding, and that is around a cost data collection tool that Medicare has started to do. That was actually mandated several years ago that they would have to do, and it was stalled because of COVID and the COVID response related to that. But we're now in that process of really understanding, by these different organizational types that you're talking about, relative to the cost. And is Medicare paying an appropriate payment? Of course, that was not, unfortunately, under the jurisdiction of this committee's charge, but it had to be considered. And so the data collection tool will be key. understanding that is another reason why the committee did not make a recommendation to a percentage of Medicare without understanding those costs. States have taken that up, but that was the reason why, that was one of the reasons why we did not take up that percentage to Medicare.
Can you all explain what the all-payer model is from the recommendation about paying for out-of-network ambulances?
Jane, do you want to take that? I know you guys have an all-payer.
Well, there's a distinction, I think, in the No Surprises Act. The reference to an all-payer system is, for example, Maryland's system, where they have the state establishes the rates for hospital services, regardless of who the payer is, Medicare, Medicaid, commercial. And the distinction there too is a number of states, probably between 15 and 20, have all payer claims databases, so that we've got access to all the claims that are submitted by commercial health plans and Medicaid, and we have some Medicare data as well. But that all payer concept roots way back to the No Surprises Act.
Okay. What can patients do right now? We're down to the last 4 or 5 minutes. I just want to try and get at least a couple more questions in. What can patients do right now to reduce their risk of a surprise bill?
Well, I'm sorry to say, if it's a surprise bill related to ambulances, it's really difficult. There are other surprise billing protections happy to share with you. Our contact information will be shared at the end. But so for ambulances, what I usually, and we can hear from others as well, but what I usually say is, you want to work really hard to get your insurance to look at and reconsider how much they're paying toward the billed charge. You want to work with the ambulance company itself and negotiate what you think is a reasonable amount or what you can afford to pay. You can also I recommend people to go to their HR department and work with their employer to see if they can step in on behalf of the patient to either pick up some of the tab or negotiate from a stronger position with the insurance company or the ambulance company. So those are some of the things that we recommend.
And I think it would be a note, and this is a really good point that Jane mentioned, if you want to avoid it, is 18 states. If you live in one of the 18 states that has, technically, if it falls under an ERISA plan, that employer could actually follow whatever the state has set for their citizens if they would like to do that and opt in as well. And I think that's, Patricia, your point as well. So that's some ways right now to help mitigate, because ground ambulance is not currently included in the NSA provisions.
And I think this report is a recommendation to Congress. And so one of the other things is to work local legislatively with your legislators and advocate for yourself that your local members of Congress review this report, ask questions about the report, and move forward to address this issue.
And let's finish by looking ahead. I'm going to combine 2 questions. What are the next steps after Congress receives the report? And can we say definitively whether the committee's recommendations will stop surprise bills?
Well, the recommendation is to ban surprise billing from 911 and for those interfacility transports that require you to go somewhere else for the care that you need. So there are many other issues within emergency transportation and emergency services that need addressing, and that a lot of that is discussed in the report. But Congress should read this report. I would hope within a week of the report, there's a bill introduced that take our recommendations, and we can start working to get our legislators to sign on as co-sponsors and pass that law. It's long overdue. We have a good couple of months before the end of the year. This is possible.
And one thing I would note is that when we were back in a time when states had passed their own balanced billing laws and Congress was considering the No Surprises Act, states had lots of discussions with members of Congress and their staff to sort of say, yes, you can do this. We're happy to share whatever we've learned. And so hopefully those same kinds of discussions will go on between the states that have acted and their delegation when that report comes to Congress. And we're happy to have those discussions and offer thoughts.
All right, it is 2:30 Eastern Time. We really appreciate having our guests, Dr. Sani, Montez, Isbire. Hope you all learned a lot, got the information you needed. If you need more information, do not hesitate, please, to get in touch with me, markm@publicinterestnetwork.org, and I will get you to Patricia, and or Patricia will get you
Mark,
to
I
other
think you have a
folks.
slide with everybody's contact information, if you'll just throw
Oh,
that up there.
wonderful. Let me
that-
do that.
But yes,
That's-
thank you everyone for coming. Thank you so much to the panelists. This was a great discussion, and it's just the first of many. We're all available. We're looking forward to hearing from all of you and talk to you. So last slide there, the very last slide, please, of that.
The last
presentation.
slide.
Yep, very last slide has everybody's contact information, I believe.
Thank you.
There you go. Thank you so much, everyone, and hoping you're having a great day. Thank you to the panelists. Thanks, Mark, for moderating and handling all the technical difficulties.